We are going to discuss speech and language treatment in individuals with motor speech disorders following a CVA. So, a quick recap: a CVA is caused by an interruption of blood flow in the brain. It can cause behavioral, cognitive, or physical deficits that affects a person's quality of life. It can also cause a variety of motor impairments, such as apraxia, hyperkinetic, and spastic dysarthria. There are others. Spastic dysarthria and apraxia are most commonly caused by stroke. So, some apraxia treatment options. Apraxia is sometimes hard to detect because it often resolves quickly after stroke. Deficits include articulation, prosody, respiration, resonance, and phonation. General principles of apraxia treatment are to help patients relearn movements of speech. So, one category for treatment is articulatory kinematic treatments, which focus on improving the timing and placement of articulatory movements through modeling, positioning of articulators, and repetition. Examples of these are the 8-step continuum, sound production treatment, Darley, Aronson, and Brown's procedure, and prompt. Another category is rate and rhythm procedures, which use controlled rate and rhythm of speech to restore natural patterns of articulatory movements. An example of this is melodic intonation therapy, which can also be used for aphasia. Another category is an alternative and augmentative communication device, which can be used when speech is so severe that it prevents verbal communication. These devices can range from picture boards to mechanical electrical devices. Another option is intersystemic facilitation and reorganization, which incorporates the use of stronger methods of communication to assist with verbal speech. Example of this would be to use a gestural equivalent with verbal production, or the combination of speech and hammer-end gestures, which is similar to ASL. And the last category is including relaxation techniques as a form of treatment. And next, we will discuss dysarthria treatment options.
A common characteristic in all dysarthrias is imprecise consonant production. Therefore, traditional articulation treatments focus on correct speech production by using intelligibility drills, phonetic placement, and exaggerating consonants. Intelligibility drills are when the clinician listens to the patient read a list of words or sentences. Feedback is provided for any unintelligible productions. Phonetic placement is when the clinician provides instructions on the correct placement of the articulators before the patient attempts to produce a target sound. Exaggerating consonants involves over-articulating to teach the patient to fully articulate their consonants. Hypokinetic dysarthria uses rate reduction and stretching tasks along with traditional articulation treatments due to the reduced range of motion in the articulators and the increased rate of speech that accompanies this dysarthria. Different rate control treatments will be discussed later in the PowerPoint. Stretching tasks include tongue, lip, and jaw stretching. They are designed to increase muscle tone and range of motion. Tongue and lip stretching tasks are also used with spastic dysarthria to help reduce hypertonicity in these muscles. Stress and intonation treatments are used when working with ataxic dysarthria to develop natural pitch and loudness variations in connected speech. In contrastive stress drills, the patient answers questions by adding stress on keywords to convey meaning. Pitch range exercises are used only if a patient can perceive pitch changes in the clinician's voice. The patient prolongs the sound at different pitch levels. Then the patient reads sentences with different pitches indicated above and below the words. Intonation profiles use lines to show intonation changes in written sentences. Rate control treatments are used to slow the rate of speech and give the articulators time to reach their target positions. An increased rate of speech can be seen in ataxic and hypokinetic dysarthrias. As mentioned in the articulation treatment slide, slowing the rate of speech in hypokinetic dysarthria can help improve articulation. This is done through pacing boards, hand or finger tapping, alphabet boards, delayed auditory feedback, and reciting syllables to a metronome. Pacing boards are devices with finger width slots that the patient uses while reading or repeating sentences. The patient is instructed to place their finger in each slot for every word they say. Hand or finger tapping is when the patient attempts to say a syllable for each tap of the clinician's hand or finger. Similar to tapping, the patient can recite syllables to a metronome. Delayed auditory feedback uses a device to play back the patient's voice at a delay while they're speaking. Ataxic dysarthria uses rate control to help reverse the patient's attempts to speed up their slow rate caused by this dysarthria. Similar to hypokinetic dysarthria, metronomes and hand or finger tapping can be used to help slow the rate of speech. Cued reading material can also be used when treating ataxic dysarthria. This is when the clinician points to the words or syllables the patient is reading at the desired rate. Another type of cueing is including slashes or spacing in the reading material to indicate when pauses are necessary.
Prosody treatments include pitch range exercises, intonation profiles, contrastive stress drills, and chunking utterances into syntactic units. These techniques are typically used when treating flaccid and spastic dysarthria. When treating spastic dysarthria, some techniques to target phonation include head and neck relaxation, easy onset of phonation, and yawn-sigh exercises. Other treatment options such as pushing and pulling procedures and the Lee Silverman voice treatment are used to treat hypokinetic dysarthria. Effortful closure is used to target phonation in flaccid dysarthria. Also, Botox injections can be used to promote easy phonation during vocal production.
To continue the discussion of phonation treatment, holding your breath, hard glottal attacks, head turning and sideways pressure on the larynx, voice amplifiers, and instrumental biofeedback are all very good treatments for these different types of dysarthria. And we found a research article that had significant evidence for the use of neuromuscular electrical stimulation on patients post-stroke as well. Moving on to respiration treatments, there is a slow and controlled exhalation, speaking immediately on your exhale, stopping phonation early, optimal breath group, correct posture, and cueing for complete inhalation. Menez and her colleagues researched the efficacy of 5 different interventions to improve respiratory function after a stroke. Respiratory muscle training had significant evidence supporting its clinical use and had proven effects of improving lung function in patients with a CVA. Lastly, we're going to talk about resonance treatments. The Lee Silverman voice treatment definitely has an effect on hypernasality. Increased hypernasality is common in patients with non-progressive dysarthria. More research is needed to draw further conclusions, but in this study, 3 out of 5 patients were able to decrease the hypernasality of their voice using the Lee-Silverman voice treatment. Surgical or prosthetic options for decreasing velar hypertonicity are available for our patients. Behavioral options such as visual feedback, reducing rate of speech, and increasing loudness are also all valid resonance treatments. We also included a dental prosthesis. It's efficient to reduce hypernasality. And last, we have our resources. So thanks for watching.